I'm going to now introduce our first speaker. We have Sarah Stranberg. She is a senior speech-language pathologist in the outpatient neurological rehabilitation program here at Stanford Healthcare. She has degrees in communication sciences and disorders from Northwestern University and the University of Minnesota. Sarah has extensive experience and interest in working with individuals with communication and swallowing disorders due to neurological conditions, including ALS, myasthenia gravis, brain injury, stroke, and Parkinson's disease, and has practiced for over 30 years in a variety of medical settings from acute care and critical care to the outpatient clinics.
Okay. Thank you, Sally. And I too want to welcome everyone to this conference. We have people from a big range of backgrounds, so it'll be great during the breakout sessions. So again, welcome everyone to our conference today. As Dr. Day said, this year's conference is rather unique in that we're really focusing on bulbar function and bulbar dysfunction across the neuromuscular diseases. And again, we have people from many different backgrounds, so my talk is really just a brief introduction to some of the key concepts that we'll be talking about throughout the course of today. And we have a really great agenda of clinical and research-based talks to go through, and then some breakout sessions where we'll all be able to discuss these topics coming from our own unique backgrounds. So first off, just wanted to define what are we really talking about when we speak about bulbar function. And I think a great definition from 2022, one of our presenters today, Caitlin McGrattan, and her group defined bulbar functions as the ability to meet nutritional needs while maintaining airway protection and the ability to communicate verbally. So in terms of many of the talks today, we'll be talking about swallowing, motor, speech, and voice, and then also the body's ability to protect the airway and clear secretions. When we speak about swallowing, that's one of the pivotal bulbar functions. Disordered swallowing is dysphagia, and many of you in the room are speech pathologists or practitioners with dysphagia, but many of you come from other backgrounds, so just going over some terminology. When we think about swallowing, it's one of the more complex functions of the human body, and dysphagia can affect any stage or a combination of stages of the swallowing function, everything from putting food in our mouth, the oral preparatory phase, through the oral, pharyngeal, and esophageal phases of swallowing. And we're really talking about a condition that can have a vast a range of severity in terms of an individual might just need to prepare a certain food a certain way so that it's a little bit easier to chew, all the way through the spectrum of not being able to swallow foods, liquids, or even your oral pharyngeal secretions and saliva. It affects the safety and efficiency with oral intake, and the potential consequences of dysphagia can be life-limiting and have profound impact on quality of life. And I've listed just a sampling of the potential consequences here. One being aspiration, or having food, liquid, or secretions enter the airway and possibly cause pulmonary complications like an aspiration pneumonia. Airway obstruction, where you have complete blockage of the airway due to swallowing dysfunction. Malnutrition, dehydration, the inability to sustain your health, your life with oral intake alone, difficulty managing secretions. There's also an indication that medication noncompliance can be due in part due to difficulty swallowing pills. So Fitzgerald in 2016 wrote a wonderful paper indicating that the primary reason for medication noncompliance in individuals with myotonic dystrophy was the difficulty with swallowing their medications. Dysphagia can have a profound impact on an individual's quality of life, and also really increase caregiver needs, whether that's adapting the consistencies of food, special feeding requirements to improve swallowing safety. So you can see really a breadth of potential consequences when swallowing is disordered. When we talk about speech, we're going to make the distinction today between motor speech and voice. So impairment in our speech is one of the impairments is referred to as dysarthria. That's one of the motor speech disorders. And this can really range in severity from perhaps a person having slightly slowed or slower rate of speech all the way up to profoundly impaired speech, where there's a significant impact on intelligibility. And that word intelligibility refers to another person's ability to understand the speaker. When speech is significantly impaired or we have loss of speech, that term is, for that is anarthria. What's really cool about motor speech is that the characteristics of a dysarthria can really tell you exactly what level of the nervous system is involved. So 50 years ago this year, Darley, Aronson, and Brown published the pivotal text out of the Mayo Clinic on the different subtypes of the dysarthrias based on the different constellation of speech characteristics. So someone with Parkinson's has a different dysarthria than someone with MS versus somebody with ALS. When we talk about our neuromuscular conditions, most of these individuals will have a flaccid dysarthria, which reflects lower motor neuron dysfunction, or spastic, which is referring to upper motor neuron dysfunction. And for many neuromuscular patients, especially our ALS patients, they likely will have a combination of both flaccid and spastic dysarthria. When we talk about motor speech, we're talking about several components, one being our ability to articulate. This is our lingual, labial, facial movements to produce and articulate speech sounds. There's resonance, or the tone of our speech. Laryngeal function, referring to our ability to phonate, and then the respiratory support required for speech, which is something that we see impaired in many of our neuromuscular individuals. Dysphonia, to break it out even more, is a disorder of voice. And you could argue that many dysarthrias have impaired ability to voice or the laryngeal component. But some individuals, particularly in neuromuscular disease, will just have voice involvement, and that would be a dysphonia. When you have absolute loss of voice, that would be an aphonia. And I bring up in this light our individuals with tracheostomy. So if an individual has a tracheostomy with an inflated cuff on the tube within the airway, they're bypassing their glottis and their upper airway. So those individuals are aphonic secondary to the tracheostomy. Albeit with the right tracheostomy or the cuff deflated on a tracheostomy, you can utilize the upper airway. So those people might be able to phonate. And again, dysphonia comes down to laryngeal dysfunction, and then that element of our respiratory support for our voice. And again, that's where we see impairment with many of our patients. And finally, probably perhaps to me, one of the hardest things to define here today is the processes involved with airway protection. And so we will be hearing from pulmonology today and with their expertise, but I tried to simplify it and provided a reference by Troche and her group about the continuum, very complex processes that make up our ability to protect our airway. Very complex, both motor and sensory processes, and it includes both our ability to cough and to swallow. And this is the function of preventing airway entry of foods, liquids, or saliva, and the ability to clear any material that's gotten down the wrong way, so to speak. We talked about dysphagia, or swallowing and airway protection as really critical life-sustaining processes. Our ability to voice and speak is critical for our ability to communicate and interact with the world. But what we're really talking about here today is this, or all of these instances. So bulbar function is really at the heart of our daily activities. And despite the complexity of the various bulbar functions, our human body is able to do most of them almost simultaneously. So sitting down, as we all are here, eating the breakfast, talking with the person next to us, these are examples of really what we're talking about here today. And so as we go through the talks, both clinical and research-based today, we want to keep that perspective of quality of life as our overreaching goal. As if the scope of bulbar function was not enough to talk about in one single conference day, we add the complexity of we're really talking about these functions over time, meaning over the lifespan. Some of the diagnoses we'll be talking about today, like an SMA, is neonate through the lifespan, while other conditions such as ALS are things with onset after birth. And then we've got diseases with different trajectories, so some being progressive with different courses in terms of the severity or the rapid versus slow progression of their symptoms. We're also talking about today multiple neuromuscular diagnoses. This is not an exhaustive list, just a little smattering, but each of these diseases affects bulbar function in a different way across the lifespan. And then kind of the icing on the cake here today is the exciting part. We've got disease-modifying treatments, rehabilitation, and really advanced interventions. We'll be hearing later today about computer-brain interface, which to me is an exciting new area. So really the complexity, we could all be here for several years talking about all the details. When we talk about the scope, how many individuals are involved, there's so much data out there. I had a hard time condensing it, so I just grabbed a couple papers, and I have a reference list available. One prevalence study done in 2020 with pediatric individuals with 14 diagnostic groups of neuromuscular disease found a pretty substantial percentage of them dealing with swallowing dysfunction or speech dysfunction, breaking it down even further to chewing and swallowing impairments, and those about a third having both chewing and swallowing impairment. For adult neuromuscular diseases, I just picked one of the papers that was done quite well, and you can see pretty substantial numbers of adults across a range of neuromuscular diagnoses as having dysphagia and dysarthria. When we talk about specific diseases, again, this could be a talk into itself. There's so much data out there, but taking some of the salient papers in regards to ALS, about a third of those individuals, actually the presenting symptom of the ALS is bulbar dysfunction. The incidence of dysphagia, you can see approaching 70% of individuals with ALS will experience dysphagia during their course of disease, dysarthria close to 80%, and more than 50% of individuals at some point with ALS will experience both swallowing and motor speech dysfunction. Some data from myotonic dystrophy, as you can see there on the slide, pretty substantial. And when you're talking about congenital myotonic dystrophy, over 80% of those individuals having impaired speech, whereas about a third of them will be nonverbal or using augmentative or alternative communication devices. And we've got a wonderful speaker speaking about AAC later today. And then finally, in our SMA population, a lot of incredible data, again, coming from Caitlin McGrattan's group, looking at dysphagia by phenotype, some other interesting studies there with 77% of individuals with SMA2 presenting with dysphagia. And then in one study that we did here at Stanford, looking at patient-reported outcome measures, 94% of individuals with SMA across the phenotypes reported issues with their voice, and 85% presented with or reported symptoms of swallowing dysfunction. So there's so many individuals involved in the care of our patients. And just from a clinical perspective, and just in terms of bulbar, so not to exclude anyone from this list, but when we're talking about the key clinicians involved in bulbar evaluation and intervention, I've listed them here on the left: neurologists, speech pathologists, OTs, registered dietitians, respiratory therapists, pulmonologists, and then otolaryngologists or ENT physicians. And we have all of these professions represented here today with our speakers and with our attendees. So it will be great to talk amongst the tables about everyone's background. When we talk about bulbar dysfunction, we are also talking about a really extended team. So physical therapists do play pivotal roles in positioning for oral intake or for communication. Many of our patients are also seeing gastroenterologists, in part for some dysphagia issues. And then the surgeons placing feeding tubes, the radiologists reading the studies, everyone is involved in the care of bulbar dysfunction. But at the heart of it is our patients, their families, and their caregivers. From a rehabilitation perspective, I wanted just to introduce two of the rehabilitation specialties that I mentioned involved with bulbar function. So I know there's many SLPs in the room, but not everybody is an SLP. So I wanted to do just a very cursory introduction to our scope of practice. And so as a speech pathologist, we can practice in a range of environments, everything from critical care through inpatient, outpatient, and the home settings. And there are also speech pathologists that specialize in palliative or hospice care. We see patients or individuals from birth through adults of all ages. And we really have the bulk of our training and education is on swallowing, the assessment and treatment of oral pharyngeal swallowing. Many of us are skilled and perform the video fluoroscopic swallowing studies and fiber optic endoscopic assessments of swallowing, and we'll hear about those things today. We also, another bulk of our background is with communication, so the dysarthrias, motor speech, voice. And then for some speech pathologists, you won't find everyone practicing in some of these niches, but for some of us, we have extensive training and experience with individuals with tracheostomies and ventilator use, and then a really incredible group of speech pathologists have the subspecialty of the augmentative and alternative communication, and we'll hear from one of those experts today. We're governed by the American Speech Language Hearing Association, and in the references I've put our scope of practice. And the other rehabilitation field really represented here today are our occupational therapists. And so this is just a tiny fraction of their scope of practice, but in terms of bulbar care, they really are feeding specialists and practice largely in our neonatal intensive care units across, at least in the United States. Some practitioners will have specialty certification in swallowing and feeding, and again, this is in the United States. I've included a link to their practice guideline in regards to their practice with feeding and swallowing disorders. They're also rehabilitation experts in upper extremity and hand function. So really the key provider for a lot of the feeding guidelines and recommendations. And we'll hear from one of those providers today. And when we talk about upper extremity and hand function, really has an impact on how people might use a communication device, how they're able to interact with an AAC device. And their national organization in the US is the American Occupational Therapy Association. when I spoke of the people involved in bulbar care, I did highlight patients, caregivers, and families are at the center of this care. And there's increasing use in both the clinical and research domains of patient-reported outcome measures. You don't have to be able to read all of these items. I just put a few of the bulbar patient-reported outcome measures that are currently being used. And there's increased research, and I cited one of our Stanford studies there, looking at the correlation between the actual bulbar function or dysfunction and how patients rate themselves. And so I'm constantly fascinated by that correlation or lack of correlation between what's actually happening in patient-reported outcome measures. And finally, as we go through the day-to-day and we talk about the different bulbar functions over the lifespan in numerous neuromuscular diseases, we have other things to consider. So one, specialized care. So the proximity of individuals across the world in accessing the specialized care that's needed. So even in California, we have people from very remote areas that need our care. And there are dedicated centers, the MDA and ALS associations, or care centers provide this multidisciplinary care, but that's not always accessible to all individuals. So one positive thing from the pandemic years was the increased use of telehealth. I feel like we've been able to leverage that to reach many individuals who otherwise can't come into a specialized care center, but something to think about as we move forward. There's also clinician expertise. So training the specialists, like all of you here, we're constantly looking for our own education and professional growth, but also about training clinicians that are new to this area or general practitioners, whether rehabilitation or related fields, and training those with a general practice on how to better work with patients with neuromuscular disorders. Increased screening tools so that providers in outlying areas can really identify who needs a specialist, who needs to go to one of the MDA centers, for instance. And then there's the growth of interprofessional assessment. So yesterday's part one of this course was the International Working Group looking at an interprofessional assessment of bulbar function in individuals with SMA. So very complex process to develop these tools, but one that's really going to add some really important dimensions to our care. Then there's the timing. When do we assess? When do we intervene? And at what intervals? Because these diseases are, across the lifespan or across many, many years. And so when do we repeat swallowing studies? When do we repeat the big assessments versus just kind of checking in? And these are all questions that we have to grapple with in our ongoing care of these individuals. And then finally, not to be the downer of this, but we do have to look at this in terms of cost and insurance. At least in the United States, the insurance company may dictate where an individual and family get their care. And not all the systems have the multidisciplinary MDA clinic or the specialist. So how do we navigate that? And then many of the bulbar functions we're talking here today need to be measured or should be measured in order to track an individual's response to the disease-modifying treatments, and sometimes to justify that the treatment be continued. So cost and insurance does play a part in how we actually do deliver care. And so just one other element. And then finally, something that I didn't put on the slide, and I wish I would have, but something that our patient panel brought up yesterday. All of this that we talk about today, all the details, all the research, really also we have to take into the perspective the patient and the family. What do they want? So we might have the fancy assessments, but those may not be wanted by the individual. And so how do we pivot? How do we meet the individual needs, the cultural needs of human function as essential to daily life, such as swallowing and communication. So we've got a big order to fill today, but we hope that we can increase everyone's understanding of these key concepts. So thank you.
Thank you, Sarah. Are there any questions in the audience? There are some that came in online, but I just wanted to give the audience a chance. Okay. No, there's questions online we have for you. So someone wrote, I always get confused by hypernasality. Is there such a thing as hyponasality? Do changes caused by pharyngeal weakness and primary sinus nasal problems sound different?
Just a really brief answer to that question. The question was hyper and hyponasality. So yes, both of those are distinct speech characteristics. So hypernasal speech is when you have airflow into the nasal cavity when it shouldn't happen for that specific a phoneme in whatever language you're speaking. A hyponasality is when there should be airflow. So in English, the nasal sounds are the M, N, and ING. So we do have airflow to our nasal cavity. If we don't have nasal airflow on those sounds, then we would be hyponasal. So when you have the colds and things going around right now and you're all congested, your speech will change because you're hyponasal.
Thank you. Another one, if you don't mind. Just in terms of initial referrals from a primary care doctor, for seemingly isolated disorders of mastication due to weakness of masseter or temporalis muscles, is it most appropriate to refer to SLP, ENT, neurology, or another specialty?
So I guess my first thought on that is if there is no medical diagnosis to support why somebody would have weakness of their masseters and temporalis, then definitely I would say referral to a neurology to get to the underlying cause. And then hopefully neurology would branch out in referring to rehabilitation specialist. So understanding the etiology is really essential because how we would manage speech and swallowing can even vary across the neuromuscular conditions.
Thank you so much.